In 2009, Ms. Reynolds was awarded the Water Quality Association Honorary Membership Award and the William B. Frisch Memorial Top 50 International Award, recognizing the top 50 most influential people in water treatment and purification industry. Ms. Reynolds.
Thank you. Good morning. Thank you for being here. Wanted to share with you about a study we've been working on for the last about a year, looking at swimming pool exposures. And as a risk assessor and a microbiologist at the College of Public Health, one of the things that we realized very rapidly is we have major data gaps in exposure assessment, meaning that you maybe heard yesterday at some of the talks, the CDC talks yesterday, there were some stats thrown out there that when you survey swimming pools in the United States, 1.9% of those pools test positive for cryptosporidium. But what does that mean? What does that mean in terms of public health? If you don't swallow the water, you're not going to get a cryptosporidium infection. So we wanted to know information about how much water do people swallow, and what are the specific site or scenario-related events that lead to that exposure, maybe increase the exposure or decrease it. Right now, we get a lot of this data to do risk assessment on exposures from questionnaires. We ask swimmers, how much water do you swallow when you swim? They give us a response, and we really don't know if people have a good perception of how much water they really swallow. And what we wanted to do is to try to develop a standardized questionnaire where responses to questions that we asked could take out that human kind of error, that human perception error, which is different for all of us, and look for different markers in the questionnaire that were less subjective, really. Are there things we can tell about if you report what kind of skill level you have as a swimmer? Can we then make some assumptions about how much water you might swallow during a swim event? Length of swim, types of swim aids you might be using, types of activities. What about your hygiene of the bathers, and how does that impact the water quality? So as we go through this talk, I'm going to be sharing with you, the basic task was to develop this standardized questionnaire, but as part of this work, we wanted to validate the responses in those questionnaires, and we used, I think, some very creative tools available to us in exposure science to look at that. We looked at biomarkers. We collected urine samples from swimmers and determined how much of cyanuric acid was in the urine, because we could tell how much water you swallowed and take out that human error. We could match that response or that result to the response in the questionnaire. We used individual monitors, sensors that people wore on their body, so we could make some measurements, quantitative measurements about activity levels and relate that back to those biomarkers. So that's some of what we're going to be talking about today, and there should be plenty of time at the end for questions. If you have a smartphone or a laptop or an iPad, something like that, we will be putting up the questionnaire link, and if you would like to link into it and follow along through the presentation today, you can do that. So, and it will be available for you to use or check out later if you'd like to. Just jot down the address for that link. So, tell you a little bit about our team that worked on this project. I was the principal investigator. I'm an environmental microbiologist, and my specialty is treated water environments. Laura Supez is a PhD candidate who is using this work for this project for her dissertation. She'll be finishing probably in May. She's working on the results of this project right now. So this is sort of hot off the press. We just finished our field studies about 3 weeks ago, Laura, right? So she's still analyzing a lot of the data, but we have some good preliminary data to share with you today. And some of you may know Chuck Gerba. He is also an environmental microbiologist, world-renowned for being an expert in kind of all things fecal, really. So I was a postdoc in Chuck's lab at the University of Arizona back in the early 90s, and he came up with the idea to do the study where we would swab people and see how much fecal matter was on the perianal area. And I remember my parents saying, "You went to school to get a PhD to do this, my glamorous life here." So, but out of that work, swabbing bodies of humans to see how much fecal matter is present, we got some really good exposure data. We got some really good data that we can use to sort of make estimates and forecasting about contamination levels we could expect in swimming pools or when people bathe together in swimming pool environments. So this was a very important advancement to the science. Also working on this project with us was Casey Ernst. Casey is an infectious disease epidemiologist at the University of Arizona, and she helped us a lot with the development of the questions for the questionnaire and analysis of those responses, and in our epidemiological study design. If you're familiar with some of the literature around health impact studies from swimming pool exposures, you know that there's a lot of mixed results out there. And, you know, asthma, it could cause asthma, it does not cause asthma, you know, the results are mixed. And what that really means is that we have a flawed study design. There are things we're not considering, things we're not evaluating properly, and that gives you sort of mixed results. Or there's a lot of variability and uncertainty around those studies. And so the purpose of what we're doing here today with this study is to try and reduce that uncertainty, get more accurate assessments of these exposures and behaviors and swimming pool operations that, you know, work together to prevent these health impacts that we're talking about. So with that, I'll go into the talk. So again, just keep in mind that our intent here was to develop a standardized questionnaire, using that questionnaire to better inform exposure assessment, get a better idea about what things happen at the pool with bather hygiene, with bather load, with operations that could lead to deterioration of water quality and associated exposures. I think I'm preaching to the choir here when I talk about the benefits of swimming and the popularity of swimming as exercise. It's the most common activity among children, and children are some of our most vulnerable populations. They're considered more immunocompromised, especially under the age of 5. They're more susceptible to infections when they're exposed to pathogenic microorganisms in water or food or in recreational environments. Plenty of swimming pools. We have good data on knowing how often people swim, the duration of swim. We have a lot of information out there available in the literature about that, and those are important numbers that we can use to help forecast what some of the risk might be to swimming activity as a whole. But again, we're missing some of the information about why recreational waterborne outbreaks are increasing. Part of it's better reporting, and better database development, but there's also other things going on like emerging infections with cryptosporidium. Even though cryptosporidium has been around for 20 years, a couple of decades, it's still considered an emerging pathogen because the numbers are increasing as we're having better recognition of those exposures. So again, we want to know not only how often you swim, but how much water you swallow, how much cryptosporidium is present in the water or other contaminants are present, so we can start to forecast this. And then we start to save money. We don't have to always run out into the field and collect samples. We can actually use risk assessment models to predict what exposures might be. And from that information, we can get better policies being set and better regulations to really address the need. Okay, so this is some of the most recent CDC data looking at outbreaks and some of the causes of those outbreaks. And just to highlight some of the things we really want to talk about here, we're talking primarily about treated water venues, so places where you don't expect to find microorganisms, but obviously we have the resistance with the cryptosporidium and difficulties there with dealing with that. Ingestion exposures are what we primarily focused on here. There's obviously inhalation exposures to disinfection byproducts and other things to consider, but for this questionnaire we really were focusing, we have all those parameters in the questionnaire, but for our analysis with the cyanuric acid urinalysis, we were really looking at ingestion and try to get better quantitative data on that type of exposure route. Acute gastroenteritis is the primary health impact that occurs from swimming that's reported in the outbreak database, and parasitic infections. Now, you might have seen some of the slides yesterday saying that when you look at a broader range of outbreak data, the parasitic infections encompass about 75% of the total microbial agents that are causing outbreaks out there. Okay, so I think this has been talked about a lot at this meeting if you went to some of the talks yesterday, but just in case you didn't, a brief background on cryptosporidium. One of the focus areas, again, is because it is resistant to disinfectants, and so we're looking at alternative methods for disinfecting pools, combined disinfectants, or filtration, better methods for removal of cryptosporidium, because it is one of the primary causes of these treated water outbreaks. I want to just point out some of the data we know here about cryptosporidium and its infectious dose. Again, another important parameter for risk modeling is how much does it take to make you sick. And with cryptosporidium, it has a very low infectious dose. You'll even see estimates from feeding studies that go below 10 oocysts. And when you think about how much a bather can shed, a single ill person can shed millions to billions of these oocysts in a single event. And so we're potentially talking about a lot of contamination in communal bathing environments. The other thing we hear a lot about is if you've been sick with diarrhea, you shouldn't swim for 2 weeks around when your symptoms have ceased. And we know that from some studies, depending on your immune status, you could shed cryptosporidium oocyst for 50 days post-symptom. So that's quite a bit longer, and a longer time period of when you might have to avoid exposures to other people through swimming. Okay, so another parameter that we evaluated in our questionnaire was exposure to disinfection byproducts through reports of respiratory illnesses. And the thing that we're focusing on primarily here are chloramines. Trichloramine in particular is being identified as the most hazardous compound that are associated with disinfection byproducts, and then some of the symptomologies that can occur here. So we did collect this data from our questionnaire. We did not have any validation tool to really verify that the things people were reporting match up with the pool operations and the pool water quality. So that's something we would like to get funded in a second year of funding, looking at these inhalation exposures in addition to the ingestion exposures. But we want to be able to use field validation data so we can really verify those responses as they're being collected. Okay, so just to summarize, the primary objective of this study, develop a survey tool to accurately assess swimmer exposures that might lead to adverse health outcomes. We're focusing again on exposure assessment, targeting site and scenario-specific events that contribute to exposure. And we wanted to also create a centralized database, and we've successfully done that. The questionnaire that we've developed is available in an electronic online format. All of the data gets deposited into our central database, and we can analyze that. We've made it as automated as possible in that your responses to the questionnaire are automatically coded. And so that takes out a lot of work typically involved with taking non-categorical data and trying to make some sense of it and group it together. We've provided multiple choice selections around some of the questions so that we can automatically code and analyze the data much more rapidly. And so we're hoping that we can get widespread use of this questionnaire across the nation in health departments. We've been having preliminary discussions with the CDC, with Michael Beach, who I see in the audience, about maybe hosting this questionnaire, making it available to health departments and epidemiologists, researchers, anybody who's interested in using it on the CDC website with the Model Aquatic Health Code information, and that's something that we hope to see in the future, that we could disseminate this a little bit easier. Okay, so I mentioned a bit about the validation of the questionnaires. You're going to hear a little bit more detail about that from Laura when she comes up and talks about some of the field data analysis. But I wanted to just talk about where we started with this study. We didn't want to reinvent any wheel. The CDC has done a lot of work, and local health departments have, many of them have their own questionnaires that they use to investigate outbreak scenarios and to evaluate operations that are occurring at the pool. But we had two goals with this project, and one was to have a questionnaire that was concise enough that people might use it routinely, even in non-outbreak situations, just to build the database of what's going on. What are bather loads like? Excuse me, what's bather hygiene like? Excuse me one second. You know, can we start to assimilate some of this data to evaluate what's really going on at the pools in non-outbreak scenarios? So that was a goal of the project. So one of the things that we definitely did was condense some of the questionnaires that are out there to a shorter format, and having it be online, we have drop-down menus that only appropriate, if you mention that you have some certain symptom or you've been exposed to some type of environment at a pool, only successive questions related to that exposure then drop down for you. So you're not wading through lots of pages of questions that don't apply. And so we've really kind of streamlined that process. We developed two questionnaires that are related in that they're analyzed in the same way, and we can cross-overlap some of the information so we can look at operations data with bather reports of symptomology. And so essentially we have two questionnaires, one on exposure assessment and one on operations assessments at the pools. And again, I mentioned some of this electronic database where we're being collected. If you're familiar with the software Ellume by DatStat, that's the software we're using. And so if you or your company has that software, there may be a way to just transfer the responsibility to you. We're hoping to host it for at least a year at the U of A so we can start to build this central database and then maybe have it permanently hosted at a site like the CDC. Okay, so some of the information we found in our literature review is that there really, even though there's questionnaires available out there in centralized places, there really wasn't uniform use of those questionnaires. So health departments were kind of using their own, taking bits and pieces from different places, and we're trying to make something a lot more standardized so that we're all using the same information, the same types of questionnaires, so we can analyze the information collectively. Cryptosporidium and trichloramines emerge as the two top contaminants in terms of microbes and chemical exposures in swimming pools. And we know that improper pool maintenance is related to outbreak occurrences, and also contamination of pool water by ill swimmers. And even monitoring events have showed us that even when people aren't reporting that they're ill, when there's not an outbreak being identified, we can still, on some level, identify contamination with cryptosporidium. So we have some questions about what are some of the long-term health effects. I mentioned that even with meta-analysis of different studies, there's mixed results. We really need a better way to assess these exposures and these health outcomes through this type of standardized questionnaire so that we can have better policy setting, better regulation, more consistency with that. Okay, one of the things that we did to add some oversight to this process was we developed 3 expert panels, and one was through the industry. Laura went to the 2012 International Pool, Spa, and Patio Exposition, and she compiled some industry experts and some volunteers ahead of time we recruited to meet with us and look at our draft questionnaires about the operations and get input from the industry professionals about what they would like to see, what some of the range of possible responses might be, so that we could have a multiple choice coded questionnaire for easier analysis. So we involved 8 select participants from the 2012 meeting who gave us some fantastic input. And by the way, this is still an evolving document. So if you log on to the link and you go through the questionnaire, we welcome any comments you have about how it might be improved or things you would like to see that we might have missed in the questionnaire. So our next step with expert review panels was an internal panel at the College of Public Health. And this is where the industry gave us some really concise information. They wanted it short. They wanted the questionnaire as short as possible that still was effective for what we wanted to accomplish. But then when we met with the scientists in academia and the epidemiologists, they kept saying, oh, you need to add this, you need to add this. So the questionnaire started growing again, which isn't really what we wanted. But we think we hit a lot of the key points, and I welcome again anyone to go in and just kind of evaluate that and help us improve that. And then our final step was, after we thought we had a pretty good draft of the questionnaires and before we actually used it out in the field with our participants in the study, we put together an external review panel. We tried to make this have as much international representation as possible so that we were considering factors with operations and pool exposures that might be different than we are experienced with here in the U.S. So we had 9 international expert epidemiologists, exposure scientists, microbiologists, and regulatory personnel participate in those review panels, and we had a couple of conference calls and some reviews of the questionnaire and had some great input for that. So we think we've developed a good product that went through some rigorous review from a variety of stakeholders. So the final application was to use the questionnaire live, and so we recruited out of from 4 different pool sites in Tucson, Arizona. We recruited 126 participants ranging from, what was our youngest? I think we had a 2-year-old, didn't we? And 2 or 3-year-old child to people over the age of 65, and so we had a nice range of participants with different ages. We visited the sites multiple times. There were different activities going on at these pools. There may have been a child's party one day. There were competitive lap swimmers working out. There were also just community pools and household pools where people were just playing the Marco Polo games, things like that. And so we got a nice range of activities that we could relate back to those biomarker studies I mentioned earlier. So this is the link to the questionnaire, and I'll apologize ahead of time. It's long, and there's not really a way to shorten it. We're limited up until you see name equals. That's the host, the stat software, what they require us to have and what the host site has. So if you want to jot this down or type this in, you're welcome to link up to this, and we'll have a couple seconds while Laura and I transition. She's going to go through and talk about the field studies with you. And this will be posted again at the end, and it's in your slide packet, I believe, as well. You can certainly contact me to get this later. I can send you the link, and you just click on the link. You don't have to type it in. But please check it out and give us feedback at your leisure.
Thank you. Okay, good morning, everyone. My name is Laura Supis, and I'm a PhD candidate at the University of Arizona College of Public Health in Environmental Health Sciences. And before beginning my doctoral program at the University of Arizona, I worked as a registered environmental health specialist for 3 years and decided to continue with an advanced degree and was interested in human exposures to water contaminants. So that's why I ended up doing this research study with Kelly on swimmer exposure validation. So if anybody doesn't have a chance to jot down these links, there will be a slide at the end, also with our emails. So if you prefer to send us an email, we can send you these links. But we're interested in improving the questionnaire still, so any of your feedback is really helpful. But just as a preview, oops, wrong button. Is it the? It's just a little arrow. Okay, so as a preview, we used 3 different formats for our questions. We used fill in the blank, multiple choice, and yes, no. So for the fill in the blank questions, we had each participant was associated with an ID number, so we needed them to input their ID number as well as their email address for future contact. And we also had multiple choice and yes, no questions, and all of this was coded in a way that for improving the efficiency of statistical analysis. So immediately after each participant takes the questionnaire, all of the data is sent to a centralized database that can be uploaded either into an Excel file or into a statistical software package like SAS or Stata. And I was able to analyze the data within 2 weeks after we got all of our responses. It was just really simple and easy because it's all categorical. So as Kelly mentioned, we also were able to shorten the questionnaire by using the yes-no responses because we applied skip patterns. So if somebody answered yes to an exposure question and we wanted more specific information about that exposure, they would be taken to a set of questions that answered more information about that exposure. And if they did not have that exposure, then they were sent to the next question. So it took about, on average, 15 to 20 minutes for our participants to complete the questionnaire. We also asked about symptoms, acute gastrointestinal, acute respiratory, skin, eye, and ear symptoms immediately after the swim exposure. And then the questionnaire platform also allows us to issue the questionnaire automatically by inputting email addresses at any point in time in the future. So we issued it a week later at a specific time. It was just sent out to their email addresses to assess any gastrointestinal symptoms that may have occurred related to that exposure. The operations questionnaire was set up. We used a similar format, so we used, again, the fill-in-the-blank, multiple choice, and yes-no questions, and this also shortened the questionnaire. And it also allowed us, we really wanted to set up something that could be used during outbreak scenarios as well as just for routine data collection. So immediately the operator is prompted to answer a question if there was an outbreak or suspected outbreak at the facility. If they answer yes, they're taken at the end to a set of questions that asks about the pool conditions prior to the outbreak to see if there are any associations with pool operations maybe related to the outbreak. If they answer no, then it just takes them to questions related to the current swimming pool conditions. So like I said, I used to be a registered environmental health specialist, so I worked as a swimming pool inspector for 3 years and tried to set up the questionnaire in a way where operators can easily understand it and can perhaps use it just for inputting information about the pool conditions related to water chemistry or flow rates or any sort of operational issues. So to validate both questionnaires, we recruited 126 swimmers at 4 different pool sites. We had 2 private pools and 2 public pools in Tucson, and based on the responses that we got on the operations questionnaire, our first site was a private pool, and that was our smallest. It was 14,000 gallons. They reported using a cartridge filter that was backwashed once a month for 30 minutes to 1 hour, and the maximum bather load was undetermined, but they reported about 25 to 50 swimmers in this pool every day. Our second private pool was a little bit bigger, 17,000 gallons. They were unaware of the filter type or the backwash frequency or the maximum bather load, but reported about 0 to 15 swimmers in that pool every day. Our largest pool reported 600,000 gallons, and they used sand filtration and backwashed about once a week for over an hour. and had a maximum capacity of 760 swimmers a day, and had a daily bather load of about 150 to 300 swimmers. Our semi-public pool was 118,000 gallons. They used diatomaceous earth and reported backwashing about every other week for 15 to 30 minutes. They didn't know the maximum bather capacity and reported having a daily bather load of 50 to 150 swimmers. Both of our public pools tested their water quality every day compared to our private pools that did not test their water quality every day. So this is just sort of a little preview of the information that we were able to collect on the operations questionnaire. So we also collected a lot of information from the exposure questionnaire. We were interested in looking at the number of times that our participants were visiting swimming pools throughout the year, how long they were spending at that pool per visit, the age at which they first visited a swimming pool, and also the length, or how many people were reporting showering before we observed them swim and for how long. And we found that on average, our participants visit a pool 72 times throughout the year and are spending about an hour and a half per visit. And they're beginning swimming at about age 2.5 to 3 years. We had 6.3% say that they showered before swimming, and the average shower duration was 7 minutes, around 7 minutes. We also compared some of the responses on the exposure questionnaire and found that reported water ingestion and gender were related, so females were more likely to report swallowing more water than males. We found the same phenomenon with age, so swimmers that were younger were more likely to report swallowing more water than older participants, specifically age 10 or less. So participants that reported 10 or less were more likely to swallow more water than participants older than 10. We also looked at age 18, since this is a common cutoff for adult and youth, and found that there was not a significant relationship between swallowing more water and reporting being younger than 18. We did also find a correlation between diving and age, so swimmers less than 18 were more likely to report diving. We asked a question about deep swimming, which we defined as swimming below half of the maximum depth in the deep end, and found that people who reported deep swimming also reported swallowing more water. We saw that people who reported having asthma also reported a longer duration of time spent at the pool per visit, and that swimming in the past 2 days was associated with use of Pepto-Bismol, which is used as a surrogate for diarrhea. So we used several tools to validate the questionnaire. We wanted to look at water quality to compare to some of our exposure data. So we took free chlorine, total combined chlorine, pH, cyanuric acid, and temperature measurements at each pool, and also looked at 3 indicator organisms: heterotrophic bacteria, Pseudomonas aeruginosa, and fecal coliforms. And then we also did urinalysis, so we looked at cyanuric acid in swimmer urine for collected over a 24-hour period, because cyanuric acid is not metabolized by the body, and it's completely excreted in urine for 24 hours after the swim. And we're using that to compare to thermometers that we had each person wear that were attached to an elastic headband. And the theory is that the temperature differential between air and water is large enough where you'll see a downward peak when the person goes underwater. And then we're also correlating that to video surveillance. So we taped each of our participants swimming, and we will analyze how many times they go underwater and for how long the duration of time they're spending underwater. So the results from our water quality data were consistent with other research. We found that heterotrophic bacteria increased as cyanuric acid increased, which cyanuric acid is a stabilizer that's used in outdoor swimming pools to stabilize chlorine against photodegradation. But if it's in high enough amounts, or if there's too much of it, it can just over-stabilize chlorine, so the disinfection efficacy is reduced. We also found that Pseudomonas aeruginosa and fecal coliforms were higher in pools with lower free chlorine. For urinalysis, we use this equation to calculate water volume. So you can divide the total cyanuric acid in urine by total cyanuric acid in pool water and multiply it by the total volume of urine collected in a 24-hour period. We had 46 participants of our 126 submit a 24-hour urine sample, and we collected 4 water samples per site visit at each pool to average that and use that in our calculation. And then both urine and pool waters were preserved with an acid preservative, and then urine samples were cleaned to remove impurities and analyzed by UPLC MS. So we compared the results from the urine analysis to some of the responses on the questionnaire and found that the measured water ingestion, or the water ingestion amount that we found through urine analysis, was not statistically different than the volumes that were reported on the questionnaire. So for us, this validates the question that we used on the questionnaire, so it just tells us that it is a good tool. The question we asked is a good tool for quantifying water ingestion while swimming. We also found that, unlike the questionnaire, there was not a difference between gender, so males and females swallowed the same amount of water. And also, unlike the questionnaire, participants that reported being less than 18 were more likely to swallow more water than participants over 18, and participants less than 10 were not likely to swallow more water than participants over 18. And also that measured water ingestion was associated with diving, the activity diving. And if you remember from one of the previous slides, being under 18 and diving were associated. So the hypothesis here is that participants between age 10 and 18 are diving more, and during this activity they're likely swallowing more water, but they're not perceiving that they're swallowing more water. So both the evidence from the gender and the age sort of tell us that there's this perception issue among those populations, that they're swallowing different amounts than they actually are. So here's a graphical representation of our water ingestion data per hour. The darker bars are participants less than 18, and the lighter bars are participants over 18. So you can see that it makes sense. There was a statistically significant relationship between swallowing more water and being less than 18 than over. So overall, we found that all of our participants swallowed on average 13 milliliters of pool water per hour, that participants less than 18 swallowed 23 milliliters per hour, and that participants over 18 swallowed 11 milliliters per hour. So we're currently analyzing the data from our temperature sensing headbands, and Al Dufour from the US EPA actually developed these headbands. For anybody who's heard of what an eye button is, it's a thermometer that it looks like a little battery, but it can be used to measure temperature over time and can be plugged into a computer, and the data can be uploaded. So we color-coded 15 headbands with these eye buttons, and then the colors were associated with an ID number, so we could tell the participants. And the purpose of color-coding them is so that in the video analysis, we can tell who we're watching, what participant, and then associate that with water ingestion and some of the other factors we're looking at. So we color-coded 15 headbands, so up to 15 swimmers per site visit wore these headbands. Some days we had less. And again, the theory is that when the person puts their head underwater, the temperature will decrease, and you'll see these peaks on the graph. So this is actual data from one of our participants, and based on the downward peaks, we estimate this person put their head underwater 7 times. And Al Dufour is currently analyzing this data, and he's looking at number of head submersions and also cumulative time spent underwater using this information. So again, theory is that these will predict head submersion counts as well as cumulative time underwater. And because we analyzed each of our participants with video, we are hoping to be able to correlate the data from the temperature sensing headbands with the video surveillance, because we're going to be able to see exactly what the swimmers are doing because we recorded their behaviors. So for the video surveillance, we're using an application. It's a digital stopwatch. It can be downloaded on either a Droid or an iPhone, and we're watching 10-minute intervals of each video of each swimmer and recording total of head submersions and total time spent underwater. So this is what the application does. As a screenshot, this is out of a 10-minute interval. This swimmer swam for 2 minutes and 42 seconds and submerged their head a total of 36 times. And then we're also able to tell how long each head submersion lasts. So number 36 lasted 16 seconds. The other great thing about this application is that it can be emailed to anybody immediately after the data is collected. And it ends up looking like this. So since the x-axis of the data from the temperature sensing headbands is time, and since we know the time on the video at which the video analyzers are pressing start on the digital stopwatch, we're going to see if we can correlate the start times with the times on the temperature sensing headbands to see if that's actually when somebody put their head under the water. So we have a lot of data to analyze still, but we're working on the videotapes and the thermometers, the temperature sensing headbands, and hoping to correlate those. We're also hoping to correlate the temperature data with the ingestion data, because in marine or freshwater swimming scenarios where they're not using cyanuric acid, there's no good way to measure, to directly measure water ingestion of those swimmers. So if we're able to correlate water ingestion with these temperature headbands, they might be a good way to estimate how much water is being swallowed during marine or freshwater swimming. So we would like to thank the National Swimming Pool Foundation and Research Foundation for Health and Environmental Effects for funding this project. And here's another slide with the links to the questionnaire. Again, we would really appreciate your feedback, or if you prefer getting an email from us with the links, please send Kelly or I an email, or if you have questions or anything like that, we're happy to answer them. So.
Well, thank you very much. A lot of information in a short amount of time. Any questions?
You mentioned about cryptosporidium infection, and that really is obviously a very difficult infection to clear from water sources. In drinking water, one approach is to use chlorine plus UV. Do you notice in your studies or in the literature review that there's a reduction in infection among swimmers in those pools that use both disinfection methods, chlorine plus UV versus just chlorine alone?
Okay, the question's relating to cryptosporidium in a chlorine-only facility as well as chlorine with UV.
Yeah, and I don't know that the data is parsed out like that. Michael, maybe you know from the CDC surveillance data. I don't think we have enough information on that to be able to say that there's an improvement in outbreaks related to that type of treatment. Would you agree, Michael?
Yeah. The granularity of the data is nowhere near the answer to that question. Not a question, but a comment on from a New York State Health Department. And as far as reporting, I mean, your end goal is to have states and have database populated. I guess can't speak for everybody, but I can say that state or local health department is highly unlikely to be sending their data to, say, a private entity like that. I'd suggest, especially there's a lot of good information that you're collecting and validating, that our reporting anywhere would be the CDC, probably to the NORS system, and to get widespread use of this, suggest partnering closely with CDC and incorporating it, because I think it's just highly unlikely that your efforts are going to result in a good comprehensive reporting unless it's the CDC.
Yeah, and I agree, and that's why we do hope to partner. Oh, I'm sorry. The comment was health departments are unlikely to send their data to a private company or private entity for analysis. And so it would be best to partner with the CDC so that they could host this questionnaire, and that's where the data would be compiled. And that would be ideal. We would like that.
Not just if they would host it, but even if they're hosting it, we're not going to report. We report directly to CDC through their reporting mechanism, but even not, not to somebody that's not was separate when hosted by CDC.
Yeah, Michael.
So I guess sorry, I lost my voice after this.
Well, you haven't hardly been talking. I mean, goodness gracious.
So one of the issues I think is that what I would recommend at least is this stuff is what we really need. You've been talking about exposure and all that. I wouldn't spend as much time on dealing with building a database that you move. I can tell you that's not going to be possible.
Okay.
I mean, because what you'd be asking is, first of all, for us to take on a brand new database at CDC, but also that the states would have to enter things separately. I can tell you it will say no, it won't happen. So really the way that we would want to see something like this happen is integrated into the National Outbreak Reporting System, so it's part of the same, it's a separate module that comes up under that. And so
Right.
that would be the way to really do it, because states absolutely hate if CDC comes up with a new way to enter data that they now have to enter things in two different places. So,
Right. And I agree there's that challenge, and I think that hurdle, and that will be addressed long after we've gone on, we've progressed past this project. But the goal is still to have a way to have this data analyzed in a centralized way with operations and exposure data, and that's not currently occurring. And I think that will help add power to these types of studies, to validate some of the things that we've been finding, to inform risk assessment, to inform better EPI design. So it's still a goal we have. I agree that it's a challenge and maybe at this point impossible, but I think that some of the things that have come out of this study is a new way to validate some of these responses so that we know more about the accuracy of what people are reporting, what they're perceiving, what their behaviors are. But I still want to hold it out there that we want to have some kind of central depository so we can have more power and assurance that we're making the right decisions in policy.
don't get me wrong, I'm actually
Yes,
that is important. Just don't spend a lot of time on the method which you collect the data in,
right,
because that's probably not that. Validation is what's really key here.
right, I agree.
I'm interested in the respiratory effects of the disinfectant byproducts. And could you talk a little bit about how you plan on validating that observation?
Yeah, so our plan is to actually, sorry, I keep forgetting to repeat the question. So the question was how we would validate information we might be collecting on inhalation exposures to disinfection byproducts. And part of the way we would be doing that is to actually collect air samples, look at the trichloramines. There's some issues with methodology, not great methodology for separating out the monodiene trichloros. And so there are some things to be addressed methodologically. And that's part of what prevented us from doing that as a little side project. We were hoping to collect some pilot data on that. But to rent the equipment to just look for trichloros was very costly. And it was a limiting factor for us to do that with part of this project. So we've written a separate grant to look at collection of air samples, collection of respired air to see what people are actually breathing out, what they might breathe in. We want to collect air samples at the water level where the exposure level is for inhalation, looking at exposures during agitated water events, and then different types of activity swimmers might be involved in when their respiratory rate increases or decreases based on activity, how that affects exposure. And so again, there's some methodological issues there, but I don't think they're insurmountable, and that's something we definitely would like to obtain funding to look at further and combine these types of exposures assessments.
Following up the previous question, we have been doing in Spain some of the studies on swimmers, measuring before and after. I will report later about some of the results where they're published anyway. But among the big issues we had was precisely to measure the exposures in the individuals. We have all these problems, technical problems of measuring the
To summarize, we have information, or I guess corroboration, that there's difficulties with the methodology, and we don't have good biomarkers to really measure disinfection byproduct exposures in the body, and so there's a plea for better technology and development of those methodologies.
One last comment to that. We have a lot of data in medicine about chloroform and chloroform's excretion because of its anesthetic use. And measuring THMs, chloroform is one of the component THMs, and so measuring that, and I'm real excited about you getting urine samples because you could measure THM in the urine, and we know the biodynamics of THM in the body.
Right, so thank you for that comment. So the comment, to summarize, was that the medical field has a lot of information on chloroform exposures in the body, and that urinalysis could be used to look at chloroforms in urine. And we actually do have those urine samples archived, and we were just talking yesterday about what would it take for IRB to let us, the Human Subjects Board, Approval Board, to let us look for the chloroform, even though that wasn't part of the original consent with the participants. Do we have to reconsent our participants to look for other types of markers in the urine? So we are considering that. So thank you for that.
Any other questions?
Lori's data reported much smaller amounts of ingestion, I think, that are in EPA swim model. You want to comment?
Yes, good point. Definitely, what we're finding here, and this is a population that we're not sure how generalizable it is to the larger population, so that's epidemiologically some of the things we're sort of looking at. But certainly our values tend to be lower than what's in the swim model, which is 100 milliliters. That's what's typically used for risk assessment, which is probably an overestimation of the risk. And so that's part of the point of this project, is to get more accurate possibilities for a distribution range that could be used in risk models to look at the minimum and the maximum exposures and the distribution, what that looks like in between. So, but we're actually in line with more of Al Dufour's studies where he also looked at cyanuric acid in urine, and his exposures were much lower, a little bit higher than ours still, but much lower than what's used in the current risk models.
Kelly, what do you think about this no difference between kids and adults?
Yeah, that is interesting. The question is what I think about no difference between kids and adults, and I think one of the things we wanted to look at was skill level. Maybe it doesn't matter so much what age you are, but what skill level you are in swimming and what activities you participate in when you swim. I mean, my mother-in-law will never get her hairdo wet, so she will never be exposed. So she's one of those people in that category where she will never swallow water. There's no risk for her for cryptosporidium. So I think we need to look at that a lot more, and I think behaviors is so important. Somebody mentioned yesterday in the talks that what are these social behavioral factors, and we're just sort of scratching the surface of that, and I think we can do a much better job at quantitating those and getting more accurate assessments. It may not just be age dependent, but skill and activity dependent, and that's what we're trying to track. So thank you.
Well, thank you very much. Stay on.